All right, good morning and happy Friday to everyone. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we would like to welcome you to today's webinar entitled Complex Trauma and Substance Use Disorders Applications with Carie Rodgers. This webinar is being made available through a collaboration of the Florida Department of Children's and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. One helpful hint is the archive video displays what looks like to be an error message, but it's only a delay buffer. Ignore it, hit play, and enjoy. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You must first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of the registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive C&E credits or to access your statement of credit. Please note that the evaluation will close at midnight on Tuesday, March the 24th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you were certified with the Florida Certification Board or licensed outside of the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees, and it provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I'd like to introduce our presenter today, Carie Rodgers. She currently serves as the Education Director at Amar Institute and is a clinical professor of psychiatry at the USCSD School of Medicine. Prior to joining the team, she was the Associate Director of the Education and Dissemination Unit at the VA Center of Excellence for Stress and Mental Health in San Diego, California. She has served as the National Trainer for the VA's Cognitive Processing Therapy Initiative and as a consultant for the National Center for PTSD. She has provided training and consultation to hundreds of mental health providers in the VA and the Department of Defense, as well as in the broader community. Dr. Rodgers was also a consultant for the VA's national rollout of prolonged exposure therapy and was the director of VA San Diego Military Sexual Trauma Program. She received her Ph.D. in clinical psychology in 2000 from the University of Oregon and completed her internship and postdoctoral training at UCSD in the San Diego VA. A licensed clinical psychologist in the state of California, Dr. Rodgers is also board certified in clinical psychology by the American Board of Professional Psychology. And now I would like to turn our presentation over to Carie Rodgers. Welcome, Carie.
Thank you so much. Can everybody hear me? I am hoping so. I'm not seeing. Oh, great. Thank you, somebody, for saying that you hear me. I appreciate that. Let's see. I am going to try to switch the slides, and here we go. Thank you so much for participating today. It's an honor to be with you. As Corona said, I am the education director at Psych Armor Institute. We are a national nonprofit that works to educate the nation about ways that civilian Americans can support and understand better the military service member, the veteran, and their family. It's our goal to really help bridge the divide between civilian America and the military service member. I've spent a lot of time, I think you heard in the introduction, at the Department of Veterans Affairs. And so I worked for years treating trauma, and many of the folks that I worked with also had substance use disorders. And so I'm pretty clinically experienced in this way, and also have some knowledge of the literature around this topic area. We spoke, Corona and I, yesterday as we were talking about this presentation, and I am pretty open to having people ask questions as I'm presenting. So if you have questions about what I'm presenting as I'm doing it, please feel free to type those in the chat, in the QA. I will ask Corona and Eric and anybody else who's on from FADA to monitor those things, and please interrupt me if there's a good question or a really relevant question that comes up. I'm happy to try to take it while I'm presenting. If that doesn't work out, then we'll make sure that we have some time before a break and before we are done today, so that I can answer any questions that do come up to the best of my ability. Today we're going to be talking about a few things, and our goal for this presentation is to really explore and discuss the connection between trauma exposure and substance abuse. And as you'll see as we go through this, there's a pretty profound impact of trauma for many people, and it has a very strong impact on substance use. In addition, substance use has a pretty profound and strong connection to trauma exposure. So we're going to talk about the way that those things interact. I'm going to spend some time talking to you about how trauma-related symptoms can really get in the way of people engaging in treatment. I think that'll be an opportunity maybe for some good questions or even comments from all of you. I'm really interested in hearing your observations and thoughts about that. But we will spend some time talking about what I think is the primary driver of barriers to treatment, and it's avoidance, really, which is a major symptom that people have after they've been exposed to trauma. So we'll spend some time on that, and then I'm going to spend the last bit of the presentation talking about a couple of treatments that incorporate trauma treatment as well as treatment for substance abuse and substance use disorders. We have moved a lot in this field in the last couple of decades in the way that we think about treating substance use and treating post-traumatic stress disorder or other symptoms that can result from the impact of trauma, not all of which are post-traumatic stress disorder. But we've really changed the way that we think about treatment, and so we'll spend some time talking about that as well. So as many of you know, perhaps all of you know, substance use disorder is a significant problem in our country as well as globally. And I know we're all starting to think about things more globally, health issues particularly. I am in California, and we have been told that we are sheltering in place now. So I'm really thinking about the global impact of illness this morning as I sit in my home doing this presentation. So really, substance use disorder impacts not just those of us in this country, but it affects people globally, and it affects millions of people. It is a significant public health problem. In fact, it leads to many, many deaths in this country. In 2016 alone, I read recently that over 42,000 deaths can be attributed to opioid misuse and addiction. So it's a major problem in this country that leads to morbidity and mortality. Tobacco use, which is also a disorder or a substance that you can be diagnosed with a substance use disorder for, is also a major health condition, and it is one of the leading preventable causes of premature death and disease in our country. So, as many of you know, the majority of lung cancer deaths can be attributed to smoking, and about a third of all cancer deaths can be attributed to smoking. It also is one of the leading causes of disability in this country. So public health impacts are huge. Substance use impacts mental health as well as physical health. About half of people who experience a mental illness at some point in their lives also experience a substance use disorder. And people with substance use disorders often have comorbid chronic physical health conditions. So these include things like chronic pain, cancer, heart disease, and sometimes there's a really complicated interaction there as well, right? So managing chronic pain, managing cancer pain, the stress around other physical illnesses can sometimes increase people's use of substances as well as being caused by substance use disorders. So it is a really, really challenging public health issue. In fact, substance use disorders are linked to cardiovascular disease, heart disease. So the impact is really broader than I think many, many people are aware of. It also obviously impacts relationships and occupational functioning. I don't think I need to tell all of you how the impact on families and on occupation really gets in the way of people being healthy. You know, there's some statistics that folks with alcohol use disorders miss about 34% more days in their work life than other workers. And they're also, as you can imagine, more likely to experience workplace injuries. They're more likely to be fired or laid off than other employees, and they have a higher work turnover every year than folks who do not have alcohol use disorder in the workplace. Lifetime marital dissolution is significantly higher among folks who are substance use disorders than those who are not. So it's a real problem in our country. And unfortunately, the saddest statistic that I'm aware of, and one of the saddest statistics that I'm aware of about substance use disorder in our country, is that only about 10% of people in need of treatment get treatment. So we have a poll here. I'm really curious to hear more about you all and your patients or clients. So I'm wondering how many of you provide care for people or supervise those who provide care for individuals who have a substance use disorder? So there's a poll up on your screen, and we'll give you a couple minutes to answer that question. Right, and everybody's doing that. I'm going to continue. And then I think we're going to see the polling answers come up soon. I'm seeing a lot of people typing in. I really appreciate that. So a lot of you run residential treatment programs, work with serious mental illness and substance use.
Do you think so? Yeah. That's what we hear from Waiting. I said, okay.
Hi, I think somebody's got their phone unmuted. If we could have everybody mute, that would be great. Okay, yeah, it looks like over half of you, a little over half of you, have direct contact with folks who have substance use disorders and provide treatment directly or supervise people who do. So, so it looks like we've got a lot of experts in the conversation, which that's fantastic. So I look forward to knowing that. I look forward to your comments and your questions as we go through the presentation. I am a big fan of having as much interaction as possible, and I know that's a little bit challenging over the internet, but I will be trying to take a look at those chats and those questions as we move forward. So as I mentioned to you, and as all of you I'm sure are aware, substance use disorder in the United States is a massive problem. The data that you're looking at on the screen are from the SAMHSA's National Survey on Drug Use and Health. This is for folks over 18. But as you can see, there are 19.3 million people over the age of 18 in this country who have a substance use disorder. 3/4 of those folks meet criteria for an alcohol use disorder. About 40% meet criteria for a substance use disorder that is attributable to illicit drugs. And about 4 million people have marijuana use disorder, which is a pretty high number. It's in fact the most commonly reported drug used that's not alcohol or tobacco. I guess in some states we can't really call it an illicit drug anymore. California, not so much, but I think we understand the general idea. About 13% of the folks who have substance use disorder in this country meet criteria for both an alcohol and another substance use disorder, not including tobacco. So that's a lot. Folks are not just using one substance largely. And the incident of, in this data, which is 2019 data, of folks misusing opioids is estimated to be about 9.6 million. And that actually is down from the same numbers in 2015. So it used to be, the estimate was around, it was about 11.5 million people over the age of 18 years. We think that that is because the number of people receiving treatment for opioid use disorder, specifically medication-assisted treatment, is up. And so one can't be 100% sure about the change in those numbers and the causality of that, but we're really hopeful that treatment is one of the reasons that the number of people who are actively diagnosed with substance use disorder in the U.S. or meet criteria for it when we look at opioids is down. Again, I mentioned that this is a massive public health issue. The estimates are that it costs this country $442 billion each year in healthcare costs. It includes lost productivity estimates and criminal justice costs. Substance use disorders are really impactful in the criminal justice system, as one can imagine. So, substance use disorder in the DSM-5. This has changed a little bit. It's been a while since it changed, but we now have criteria in the current DSM for substance use disorder. Those of you who have been practicing for a while know that we used to have, in the last iteration of the DSM-4, substance abuse and substance dependence categories, but those have been replaced with this single category, substance use disorder. So what they did in the new manual, it's not that new anymore, but was include the 7 substance dependence criteria and 3 of the 4 substance abuse criteria, combined those, and we now have 11 diagnostic criteria for substance use disorder. They took out the criteria that there needed to be recurrent legal problems because it really wasn't a very sensitive symptom criteria, and they put in craving as a new criterion. Substance use disorder is measured on a spectrum now from mild to severe. So the severity level, as you can see, is determined by the number of diagnostic criteria somebody meets. So 2 to 3 symptoms of the 11, we would diagnose somebody with mild substance use disorder. 4 to 5 symptoms is moderate substance use disorder, and 6 or more is a severe substance use disorder. We measure those symptoms in the last year. Should also mention that each specific substance is addressed as a separate substance use disorder. So when you're assessing and treating, you're looking at specific substances that people are using. So alcohol, cannabis, hallucinogens, opiates, inhalants, sedatives, stimulants, and tobacco are all things that you can give a diagnosis of substance use disorder for, but you give that diagnosis with the particular substance the person meets criteria for. But most of the substances are diagnosed based on the same overarching criteria.
Carie, we had a person ask if you could provide numbers for women.
Off the top of my head, I do not know the numbers for women. I can find them for you. What's the best way to get people resources after the talk?
We're going to post the presentation within 30 days at our website, so we can add that information.
Oh, perfect. That's great. Yeah, we can definitely find that. In fact, the numbers, if you look at the last slide, let me move. The SAMHSA National Survey on Drug Use and Health, it does have breakdowns by age groups. It has breakdowns by gender. So you can also take a look, and that is linked in the resource list on the reference list in slide here. So you can go to that national survey, and they break down their numbers in lots and lots of different ways. So there's a citation at the end. But I do not, off the top of my head, know that breakdown by gender. Thank you for the question, though. It's an important one. So you see here the symptoms for substance use disorder. I'm not going to walk through each one of these. I think you can all look at them and read them. And many of you probably know these very well. More than half of you that are regularly working with folks with substance use disorder probably know these really well. But as I said, regardless of the particular substance, the diagnosis of substance use disorder is based on a set of behaviors related to the use of whatever the substance is that somebody has a problem with. And these can be broken down into 4 main categories. So I didn't break them down on this slide this way, but you really want to think about impaired control. social impairment, risky use, and physical and pharmacological indicators like tolerance and withdrawal. So impaired control are things like symptoms of waiting or using for more time than intended, or using larger amounts than intended. So lots of folks who have substance use disorder have a very, very difficult time limiting the amount of the substance that they use. So people will say, you'll hear things like, I'm just going to have one drink, and they end up having 6 or 7 because they just don't have the control over the substance use. People will talk about wanting to stop or wanting to reduce the use, but they just can't seem to do it. Lots of folks will talk about spending a lot of time getting substances and using them and not having control over how much time that's taking out of their lives. In addition, cravings, the new symptom of cravings, is part of this cluster of symptoms under impaired control. So the cravings are so intense that for many people it's difficult to think about and do anything else. Social impairment is another cluster. So folks really talk about work absences, poor school performance, not taking care of their family obligations, maybe neglecting their kids, not meeting household responsibilities. We also talk about folks having the interpersonal problems because of substance use and then not being able to continuing to use, even though that's happening. And giving up and reducing meaningful social activities, things that they really love, that they used to really do, spending less time with their families, maybe not playing golf with their friends anymore, and because they're using substances instead. It's an activity maybe that was very important to them at one time. We also see in this a cluster, symptoms that cluster around risky use. So you'll see people repeatedly use substances in dangerous situations. So you think about driving under the influences is one of those things that you'll see. You see in tobacco use disorder often folks who continue to smoke despite having respiratory disorder, despite having asthma or COPD. So those are risky use of a substance, and people can't seem to help continuing the use. And then tolerance and withdrawal, right? So tolerance is when people need to increase the amount of the substance that they use to achieve the same desired effect, right? So, you know, it used to only take a couple drinks for me to feel more relaxed or feel a little more outgoing, and now it takes 4 or 5, right? And then withdrawal fits under that cluster of symptoms as well, and that's really when we start to see people have physical responses to stopping a drug, right? So we will see people feel really uncomfortable. You'll see flu-like symptoms sometimes for folks. It can be dangerous. It doesn't always require medical assistance, but it can. Withdrawal from some drugs can be fatal, so that is a very important thing to be paying attention to when you're looking at substance use disorder and treating substance use disorder. All right. We have a video I hope to show. I'm going to ask the FADA people if that happened. So this video is one produced by PsychArmor Institute. You're going to hear a conversation in this about veterans and service members. Again, what I do is largely connected to that population, but substance use disorder is not diagnosed or treated differently in that subpopulation. So a lot of what you're going to hear is generalizable to the broader population. So let's go ahead and play that Hi, okay, we're back. The question that somebody asked is, where can the videos be seen? So that was a clip of a longer video on substance use disorder. It's at psycharmor.org, and they're free to the individual learner. So we have a number of videos, and you're more than welcome to go take a look. PsychArmor is PSYCHARMOR.org. Again, there's no cost to it. It's not, I'm not marketing anything here. It's free resources, so you're more than welcome to view the whole video. All right. So let's talk a little bit about treatment for substance use disorder. And again, many of you are in the thick of this. And I, probably talking about things that many of you actually do on a daily basis. But there are lots of different ways that people get treatment for substance use disorder in a wide variety of settings. And that's a great thing, because nothing works for everybody all the time. And so it's very important for people to, treatment providers as well as clients, to figure out what's going to work for them at a particular point in their life. But I have a few things listed here. Very important to note, while some people need to have inpatient hospitalization and detoxification, detox is really not considered a treatment in itself, but kind of the first step in a process. So for the most part, really, if people don't receive any further treatment after detox, they usually resume their drug use. So it's very important to think about that as, for some people, the first step in a longer process of treatment for substance use disorder. But you can, people do intensive outpatient programs, they do inpatient programs. There's a lot of data that inpatient and residential treatment programs are really effective, especially for folks with more severe problems, including co-occurring mental health disorders in addition to their substance use disorder. There are shorter-term residential treatment programs that focus on detox and intensive counseling in preparation for more community-based treatment programs. There are therapeutic communities that people go to that are really structured, where people live. They stay there typically for 6 to 12 months. Now that varies, but that's not an uncommon length of treatment in a therapeutic community. And usually what we see is the entire community are in recovery, and that community acts as kind of a key agent of change to influence people's attitudes and understandings and behaviors associated with drug use. So they're very effective therapeutic communities, and it is one way to go. There's also recovery housing. So there are lots of places, and I've worked with lots of folks who have chosen recovery housing as one way to get treatment. It tends to be a little bit shorter term, but it's supervised. Often I've seen folks do that following an inpatient or residential treatment program, and it really helps people transition to more independent life. So many recovery programs that I've worked with, and that the folks that I've helped have worked with, learn how to manage their finances. They start looking for employment. They get connected with support services in the community. So those are things to be aware of, and some of you probably work in settings like that. Outpatient behavioral treatment is also really important. Those programs often have individual and group modalities that people can participate in. So those are things to keep in mind. There's also always anonymous community support groups, work very well, are a wonderful way for people to maintain sobriety and to stay sober. Those groups are available around the country, and they are available for multiple different kinds of substance use disorder. So alcohol as well as other kinds of substance use disorders. Super effective, and often these kinds of treatments can be combined. So Folks who are receiving behavioral treatment individually also often go to community support groups, and people who are at intensive outpatient programs, community support groups are also often a key component of that treatment. What we really like to see when we're working with substance use disorder are multidisciplinary treatment teams. So if somebody's managing withdrawal, we also like to see somebody doing behavioral treatment. It's very nice to see occupational therapists involved, helping people get back to work. So really, when all of those components are done together and when the treatment teams are really connected and communicating, you see the best outcomes. So like to encourage that and see that. The research is really clear that that kind of treatment is really the best kind of treatment. There are a number of evidence-based treatments as well. Cognitive behavioral therapy works very, very well. For those of you who don't know what that is, what we're doing when we're doing cognitive behavioral therapy is really helping people recognize, avoid, and cope with situations that they are most likely to use in. And we help them manage their thoughts, manage cravings in very specific and structured ways. Motivational enhancement, motivational interviewing techniques is also evidence-based and really helps people make the most of their readiness to change their behavior and enter treatment. And there's some very good studies that show that that kind of engagement with folks really promotes getting sober and staying sober. And then contingency management also has a lot of good evidence for it. And the idea behind contingency management, for those of you who aren't as familiar with that, is that the whole underlying theory is that we want to reward people for desirable behaviors. So lots of programs are set up to reward folks for attending treatment or maintaining program expectations if they're in a treatment program. So that often happens in a couple different ways in the community. Voucher-based reinforcement programs and incentive contingency management programs. So if you hear somebody talking about voucher-based programs, that typically looks like someone who's in recovery receives a reward for every maybe negative urine sample when they're in treatment. And typically the way those work is that the reward is low initially, but over time, the worth of the reward gets greater and greater to keep people feeling like they're accomplishing stuff. And those rewards can be exchanged for things like food or different activities, and that promotes a drug-free lifestyle. Prize management, often programs will do things such as giving folks specific prizes. So for showing up for treatment, for taking medications as prescribed, for engaging in non-substance use behavior. And there's a lot of evidence that this kind of treatment works. So I have a comment from somebody, EMDR as a modality. Certainly EMDR is used for many things. The literature for substance use disorder isn't as clear for EMDR as it is for other things. EMDR is an evidence-based practice for post-traumatic stress disorder and some other trauma-related diagnoses and symptoms. But the literature on EMDR, the research literature on EMDR for substance use disorder isn't as strong. There isn't as much for substance use. So we can't talk about treatment for substance use disorder without talking about treatment for medication-assisted treatment, specifically for opioid use disorder. And there are many different kinds of treatments that are effective And medication-assisted treatment is probably going to be our saving grace for getting opioid use disorder under control. So methadone is one way to do that. Buprenorphine, I never can say that word, is really a wonderful medication which, when taken, really reduces the risk of overdose, and it reduces cravings for opioids because it blocks the uptake of the opioid drug, and so people don't have that euphoria that they get, which, as one can imagine, really helps people to not use the drug. Naltrexone, also important. It is an opioid antagonist, and it blocks the euphoria after opioid use as well. It's been highly effective. There's also medication-assisted treatment for alcohol use disorders. So many of you have heard of antabuse, really effective. There's a massive aversive side effect of alcohol use. So if you take antabuse and then drink, you often will have a lot of nausea, vomiting, headaches. So that often is very effective for keeping people from using substances, from using alcohol. So there are others as well. Naltrexone also blocks the positive effects of alcohol, and there's some excellent data about that as well. Medication-assisted treatment is super effective for tobacco use disorder as well. So there's nicotine replacement as well as Chantix and Zyban. Those medications also help people with their cravings. And that is one of the most effective ways for folks to stop using tobacco use disorder. Tobacco use disorder is actually very, very hard. It's not that the treatment is hard to implement, but the rates of success are lower than many other substances. It's a hard thing to kick, tobacco use disorder, and so medication-assisted treatment is one very important treatment modality for y'all to know about, especially given the impact of tobacco use on public health, as I mentioned at the beginning of this presentation. All right, so I want to also talk about we're supposed to be talking about both substance use disorder and trauma exposure and the connection. Trauma exposure, much like substance use disorder, is a major public health issue. Most people, it turns out, have been exposed to a significant trauma at some point in their lives. That affects mental and physical health in very complicated ways, and it affects relationships and occupational functioning. This is the exact kind of outcomes that we see when we look at substance use disorder. So when you've got both substance use disorder and trauma exposure with symptoms that follow, we get quite a large impact, a large negative impact. So I want to do another quick poll. Want to see how many folks provide care for folks or supervise people who provide care for individuals who've experienced trauma. So I'm going to, while you guys are doing that poll, there's a couple of questions. Nellie says, I work in a crisis stabilization unit, and they only do inpatient detox, but often the patient is unwilling to enter long-term treatment. How can we help them accept and enter long-term treatment, as we often see the same patients over and over? It's a really good question, Nellie. One of the things I would highly recommend is taking a look at motivational enhancement, motivational interviewing. those techniques have been proven to be really effective for helping people begin to see the impact of their substance use and to get more motivated to change. And so really what we see in that literature is people moving from thinking about changing to being more interested in changing and then to finally being ready to change. And there's a whole literature about helping people move through that process. So doing things like helping them see the pros and cons of their substance use, and really taking an honest look at some of the things that keep them from wanting really to engage in treatment. There's some literature as well about substance use disorder that would suggest that people who, and this is very true for tobacco use disorder, the more time you try to quit, the more likely you are to eventually get there. So for many people, sobriety is a complicated thing and they go through treatment more than once. But that doesn't mean that that is a bad thing, although we'd love to see people be able to get through treatment and stay sober. It doesn't always happen that way. So for many people going through treatment 3 or 4 times, that's going to be when the real change happens. So one thing for you to be aware of is the literature suggests that it often takes people more than one try. And so maintaining your own hope about that, I think, is really important. All right, let me look at the results of that polling. It looks like many of you, a little over half of you, do actively work with individuals or supervise people who have experienced trauma. Some of you are saying no, but most of you do. And just taking a quick look at the chats too while I do this. Some of you are working with students ranging even from 3rd to 8th grade. Trauma is definitely prevalent, unfortunately, across the age span in this population. Some of our patients, both in and out, Lulu says, of the substance abuse program also have trauma diagnosis. Is there any reason, Natalia, is there any reason why those who take care of people who have addiction often don't take care of themselves? I think that's a really good question, Natalia. Many of us in the helping professions, unfortunately, get so wrapped up in that work that we neglect to take care of our own mental health. And it's an important thing to keep in mind that in order to be helpers, we need to maintain our own health. So it's a good comment. Thank you for that. So just to be clear, I don't think that many people are aware of this, but trauma exposure in this country is actually super common. Approximately 90% of the population reports some trauma exposure in their lives. That doesn't necessarily mean that they are going to have a mental health diagnosis. Only about across the lifespan, only about 8% of people meet criteria for a diagnosis of post-traumatic stress disorder. And as you are probably aware, in order to have that diagnosis, you have to have a significant trauma exposure. Trauma exposure, while it doesn't always predict, while most people who have trauma exposure don't necessarily end up with a diagnosis of post-traumatic stress disorder, trauma exposure does predict impairment. And so repeated trauma exposure increases the likelihood of impairment. In fact, in the literature, we see specifically that that the more frequently or the more often one is exposed to trauma, the more likely they are to have impairment. So if you've had one event of trauma in your life, you are less likely than somebody who's been repeatedly exposed, who's gone through trauma multiple times, to have some kind of impairment in social or occupational functioning or mental health. Defining trauma, an excellent question. Let's take a look at that. For in order to get, we define trauma in multiple different ways. In the DSM-5 criteria for a trauma, and that would be for a diagnosis of post-traumatic stress disorder, and much of the epidemiological studies look at trauma in the population, whether somebody has a diagnosis of PTSD or not, use this definition, is somebody who's exposed to a serious event that threatens death, and that can be actual or perceived threat of death. So if somebody believes that they are likely to die, that counts as a trauma. But where they are actually threatened with death, serious injury, or sexual violence. So that can be by direct exposure to oneself, one's own physical integrity is threatened, or witnessing the trauma. So seeing somebody else or knowing somebody else who's close to you who's been traumatized can also result in a trauma, especially if that is somebody who's a close friend or a relative. It does not include indirect exposure, so watching something on television or seeing something in photos, unless that happens in the course of professional duties. So first responders, medics, folks like that, if they are frequently exposed to trauma via photographs. So I've worked with folks who have been first responders who don't necessarily go to crime scenes but see crime scene photos often. That would certainly count because of the repeated exposure in that way. So that would be something that we would consider a major trauma. So let's talk a little bit about post-traumatic stress disorder. While this is not the only diagnosis that can result from trauma exposure, it's one that I think people think about most of the time when they think about trauma exposure. So for a diagnosis of post-traumatic stress disorder, one has to have been exposed to the kind of trauma that we just talked about. If somebody hasn't been exposed to that kind of trauma, the other symptoms may be experienced, but you still can't give them a diagnosis of post-traumatic stress disorder. So the first thing that somebody has to have in order to get a diagnosis of PTSD is exposure to a trauma and the kind of trauma that we just talked about. Then you have to meet criteria in 4 different symptom categories, some of which I'm sure you have all heard about. I think the one that is most commonly thought of when we think about PTSD are intrusion symptoms. So those are the kind of classic PTSD symptoms. You have to have at least one re-experiencing or intrusion symptom. That would include stuff like nightmares, flashbacks, unwanted, upsetting memories. So people will talk about sitting having their coffee in the morning, and a memory of a trauma will just come to them unbidden. They're not trying to think about it, but it just shows up. And kind of the unwelcome guest at your party. I've heard many people talk about it like that. And that after those experiences, those trauma reminders, people get very distressed. They have physical reactivity, so their heart will race, they'll sweat. So if you're working with somebody who's got that kind of a symptom profile, they're certainly meeting criteria for re-experiencing or intrusion symptoms of post-traumatic stress disorder. Avoidance is a big one after trauma. Even folks who don't have post-traumatic stress disorder but do have trauma exposure will often avoid things that remind them of the trauma or things that make them feel the way they felt during the trauma, so they'll avoid anything that triggers memories or triggers even physiological responses to the trauma. So that's a real common symptom after trauma, and we're going to talk more about that in a bit because that gets in the way of treatment. I think that is the symptom cluster that is most likely to keep people from getting treatment for trauma-related symptoms as well as getting treatment for substance use disorder. So that's something that is also required, that that particular kind of symptom is required to give somebody a diagnosis of post-traumatic stress disorder. We also talk about negative distortions in thoughts and in mood. So these are things you often see negative thoughts or feelings getting worse after trauma. So you'll see people talking about decreased interest in activities, difficulty experiencing positive things. I've had many people say, you know, it's like I can't feel happy anymore. Folks who blame themselves or have exaggerated symptoms of blame after trauma, that's a very common distorted cognitive pattern that we see. And so having a couple of symptoms in that cluster is also important for diagnosing PTSD. And then you'll see changes in arousal and hyperactivity and reactivity. So people will talk about hypervigilance. They'll talk about startling really easily. They'll talk about having trouble sleeping, not just from nightmares, but just insomnia generally. Difficulty concentrating. People often talk about difficulty concentrating following trauma. Sometimes that's because of flashbacks and nightmares, but sometimes that's just because they're so hypervigilant. They're trying to pay attention to danger in the environment so much that it's very hard for them to sit and do tasks like reading or working. So those are important things to be paying attention to as well. We have to have those symptoms for more than a month in order to get a diagnosis of PTSD. And they have to, as all things in the DSM, have to create distress or functional impairment. All right. So I'm going to let the FADA people take back the presentation. We're going to watch another video about post-traumatic stress disorder.
Important to remember PTSD occurs. A person lives through something horrible or terrible, directly, by witnessing the event, by hearing about it happening to someone he or she cares about.
Great. So I got a couple quick questions that I wanted to. I was reading while you guys were watching the video. Someone asked, can a child or youth present with both PTSD and ADHD? Absolutely. That is absolutely possible. They can be comorbid, right? So there isn't any reason that they can't. PTSD and depression are also very commonly diagnosed together, and there's an overlap in symptoms, and so it can be tricky to figure out that diagnosis. You have to do a pretty thorough assessment, but certainly if somebody meets diagnostic criteria for both post-traumatic stress disorder and ADHD, those diagnoses can be given together. Again, just like depression, sometimes the symptoms overlap considerably, but it doesn't mean that both diagnoses can't be present at the same time. So you saw in that video, again, I mentioned this before, where I work, we are specifically looking at these issues in service members, veterans, and the military connected community, families, and military allies. A lot of the stuff that you saw in that video, though, in fact, most of it, is applicable to the general population. These diagnoses, while they look somewhat different for different subgroups in our population, the overarching themes are the same, and the treatments, frankly, are often the same. So wanted to just mention that as well. And I hope that you enjoyed the videos. I really like them. I think they're really great, and they are available, as we said before, at psycharmor.org. For those of you who are working with folks and might want to show patients those videos, that's something I often encourage. Those can be a really nice way to start talking to your clients or their family members about what may be happening with their loved ones. And so, please feel free to use them in that way. I think that they're really helpful. So I'm getting some comments. I think they will work well with my clients. Absolutely. I think that that's a wonderful way to use them. I'm getting a question from Lulu. Perceived personal threat, does this include psychotic symptoms? No, it does not include psychotic symptoms. Lulu, I think you're talking about the, let me go back to the diagnostic criteria for post-traumatic stress disorder and criterion A. Event, no. So they need to be actual events for sure. But if somebody says, I thought, this was happening to me and I thought I was going to die, that would count as a criterion A event. So it does not include psychotic symptoms. That would be, I would be diagnosing somebody with a psychotic disorder as opposed to PTSD if there was an event that they perceived, but that wasn't actually a real event. Somebody just asked about the website for the videos, psycharmor.org. It's in the chat video. It's also, we can definitely send that out or include that in the deck. It's psycharmor.org though. And those videos are free. We're excited to have people use them, show them to your patients. It's a wonderful, that's why we made them. So it's a wonderful use for those videos. So let's talk a little bit about trauma. So I mentioned PTSD. We went through the criteria for PTSD, but trauma is really more complicated than PTSD, right? Not everybody who is impacted by trauma has a diagnosis of PTSD. There are other impacts. There is emotional impacts, physical impacts, cognitive and behavioral impacts, and they can be subtle, those diagnoses, or those, not just diagnoses, but those symptoms. So, we see a lot of things that, there's a lot of talk about complex PTSD, which might end up in not just the criteria that I just went through, but also folks will talk about having a lot of self-regulatory problems, especially if they've had trauma, particularly in childhood. People will talk about not being able to manage their emotions. Well, not having a good sense of who they are, not being able to connect with other folks very easily. So trauma is really complicated. And it impacts multiple areas of life, and substance use disorder is one of those things. So I want to talk to the FADA folks. We were going to take a break in the presentation around now. Is that still, are we still on board for that? I know
Yes,
people
this is
probably
a
need to
good
get up.
time. Yeah, this is a good time for everybody to stretch. And we're going to take about a 5-minute break. It's 11:13, so if you can be back at 11:18, that would be great. Thank you. Hello, I'd like to welcome everybody back to the presentation. Carie, there was a couple of questions that I noticed. I'm not sure if you touched base on. One of them is, are there medication-assisted treatment programs for benzodiazepine abuse or dependence?
Oh, sorry about that. You know, what I have seen largely, and I'm not a psychiatrist, so there may be newer things available, and there may be other people on the call who know this better than I do. What I have seen largely with benzodiazepines is a tapering down rather than a substitution with a medication-assisted treatment. That may be, now I haven't looked at that literature in a little bit, so that may be out of date. But like I said, what I've largely seen with benzodiazepines is a tapering down rather than a substitution, like with naltrexone, which is an agonist for some substances. So what that means is it binds to the same receptor in the cell that the opiate does, for example, and so the opiate can't bind to the cell, and you don't get the same impact of it because the agonist is already on that receptor. I do not know of something for benzodiazepines like that. And again, when I've worked with folks who are trying to stop using benzodiazepines, we've done a taper with those folks.
Okay, thank you. One more question. Does naltrexone have an injectable with 1 month efficacy? People with alcohol use disorder often skip the pill to then drink.
You know, I think somebody else answered that question on the chat, that I believe that there is an injectable.
Okay.
Yep.
Thank you.
Yep. And I was trying to answer some other questions online as well. I hope I got to everybody. We got a question, do you ever see veterans with PTSD from service and theater who have unresolved PTSD from childhood? Absolutely. Most of the folks that I worked with, which was a lot of people when I was at the VA, working with that specific population, who came in had both childhood trauma as well as trauma from their service. And that, you know, again, if you think about the fact that the more trauma exposure you've had, the more likely you are to have impairment as a result. So I was seeing more of those folks in my particular clinic come in because often the combat experience was sort of additive to the childhood experience. And so it's almost like kind of having a cup that you've almost filled up, and then one more traumatic experience kind of overflows the cup. So that it was a very, very, very common for me to see that. But that, I mean, it doesn't change treatment necessarily too much. You may work with more than one trauma, but both kinds of experiences are treated with some of the same techniques. All right, so, yep.
I just wanted to add, I was just informed that Vivitrol is a 1 month injectable.
Yeah, Vivitrol, great. Great. So thank you. All right, so I really do want to spend some time now talking about trauma exposure and substance use disorder. I want to talk a little bit about the connection, the relationship between them, and then I do want to spend a little bit of time talking about a couple of well-researched evidence-based practices for treating folks with comorbid symptoms related to trauma and substance use disorder. So, you know, it's complicated, right? And those of you who have worked with folks with this comorbidity, people between trauma and substance use know this. The relationship is really interactive. People who have substance use problems are more likely to experience traumatic events than those who don't have substance use problems. And traumatized people are more likely than other people to abuse substances. So we really have this kind of what feels like a chicken and an egg issue, right? So it's a complicated interaction, and it's really hard to figure out how they work together. So a lot of people who've experienced child abuse, who have been in wars or natural disasters or other kinds of traumatic events, turn to alcohol or substances to help them deal with their emotional pain, to help them deal with memories, to help them deal with sleep, guilt, shame, anxiety, hypervigilance. People with alcohol or drug use problems are also more likely to experience subsequent traumatic events than those who aren't actively using substances. So there's this vicious cycle where exposure to traumatic events sometimes increases substance use, and people who are using substances may be in situations which make them at higher risk for having future traumas. So it's a challenge. It's a real challenge, and it makes treatment really challenging.
Someone in the audience asked if we could discuss emotional abuse trauma briefly.
Yeah. Yeah, and certainly emotional abuse, depending on the kind of emotional abuse, can absolutely result in post-traumatic stress disorder. For some people, especially in childhood, emotional abuse does lead to sort of perceived lack of safety, right? That's kind of part of what that dynamic looks like, and it absolutely is a kind of trauma. It's a serious kind of trauma. It can result in post-traumatic stress disorder, but even when it doesn't result in that particular diagnosis, can result in other symptoms. And that, what I just talked about this complicated relationship between substance use and trauma, emotional abuse absolutely ties in here. Using substances is unfortunately one of the ways that many people who have experienced emotional abuse try to manage the symptoms related to that. So it's absolutely important to be thinking about that and being assessing for that and be talking about that as a result when you're working with folks who have comorbid trauma as well as substance use disorders. You know, the statistics are, I think, really alarming. People who have trauma in their backgrounds are more likely than others, even when you control for similar backgrounds, similar socioeconomic status, race, and ethnic status, gender, age. Folks with trauma experiences are more likely to abuse alcohol both before and after being diagnosed with post-traumatic stress disorder. So if you look at some of these statistics, 1/4 to 3/4 of people who've been exposed to violence have problems with substance use, with alcohol use. 80% of Vietnam veterans who seek PTSD treatment also have a comorbid alcohol use disorder. And when you're looking at folks who have survived sexual abuse, they have much higher rates of substance use disorders than other folks. In fact, some of the statistics are that folks who have survived sexual assault are almost 5 times more likely to have alcohol abuse disorder or substance use disorder with alcohol, and are close to 4 times more likely to have cannabis use disorder. So those rates are shocking. Those rates are really high, but I also think that they make sense because people are frequently using substances to try to manage some of the emotional, behavioral fallout from trauma. We know a lot about veterans because that's a subpopulation that's been studied a lot. So in that subpopulation, veterans have much higher rates of substance use disorder than civilians. They also have higher rates of trauma exposure. We see when veterans have post-traumatic stress disorder or a traumatic brain injury, and as many of you may know, traumatic brain injuries have gotten very common for people who have been in theater in the post-9/11 era. We see a a much higher rate of substance use disorder when folks have PTSD or traumatic brain injury. We also see increased prevalence of substance use disorders when people have had combat exposure, when they've been deployed for a long period of time, or when they've had any kind of trauma from military experience. So it's not just combat exposure, but also sexual assaults during military experience, training accidents, anything like that. Also, we see an increased prevalence of substance use disorder when folks have that kind of experience in their background. So as I mentioned, this interaction is really complicated. People who use substances after trauma exposure are often trying to manage sleep problems. They're often trying to manage feeling wound up. I've had many, many folks tell me, you know, I do a lot better after I have a few drinks. I'm not as jumpy. I'm not as irritable. It helps me forget. I always will remember a patient who said to me, if I'm drinking, I'm not thinking about the trauma, right? So people are using it to avoid thoughts and emotions related to the trauma. They're also using it to distract from other things. And, you know, I get it. And I think we can all empathize with that, right? Some of those symptoms are really debilitating. They're very serious, and people are often doing the best that they can to try to manage them. But as we all know, that using substance as a way to manage those is really a temporary solution, and it's a solution that can spin out of control very, very quickly. So we begin to see a lot of binge drinking when we're looking at folks who have been traumatized, and that starts to cause problems all on its own. Right, so it may make you feel better for a few hours, but then what happens is that takes on a life of its own, and we see more and more problems for folks. So what does that mean about treatment? It has some pretty specific implications for treatment. I want to do another quick poll, and perhaps this is the question that I'm actually most interested in. How many of you were taught that substance use disorders have to be treated before other mental health disorders could be addressed? Certainly the way that I was taught, and I'm aging rapidly, more rapidly than I'd like to believe, but so it's been a while since I was in my graduate training, but this is certainly the way that I was trained. Folks have to be sober before they can have any other treatment. So I'm going to pause for just a bit because I really do want to see what the poll ends up looking like for this question before I move on. And that poll's just about to close. So when that pops up, we'll talk about it. All right, but so, you know, so yeah, a lot of you were trained this way, but I'm really happy to see that not everybody. If I had done this webinar 10 years ago, and I used to do training at the VA all the time, I got all the time from people who treated people with substance use disorders. You can't do anything until somebody's been sober for 90 days. In fact, it used to be a policy. When I started at the VA 20 years ago, the policy across the country was you can't treat trauma-related symptoms until somebody's been sober for like 3 months. It turns out this is not a good plan, and so I'm actually really glad to see these polling numbers that so many of you seem to be on the same page about this. And if you weren't trained this way, I hope that we can talk more about this. But treatment's really challenging in folks who have complex trauma histories and are also using substances. We used to say you got to treat the substance use disorder first, but it turns out this is not a great plan. partially because people who get treated for substance use disorder who have untreated PTSD are at high rates of relapse during and after substance use treatment. So we really believe that not treating the PTSD actually puts people at higher risk of using substances again, and that is not what we want to do. Also, there's been some really fascinating research. A researcher who used to be at the University of Washington named Deborah Kaysen led some work, and you see the citation at the bottom of this slide. It was published a few years ago. That what she did was she actually had a group of folks who were in treatment for substance use disorder. They were trying to stay sober, and she had them monitor their symptoms of both substance use disorder and post-traumatic stress disorder over the course of live days, right? So she had them using tablets, and they would be monitoring their symptoms. And what she found with this live kind of in-the-moment data was that intrusive symptoms of PTSD and avoidance symptoms of PTSD actually predicted not only urges to drink, but also drinking in people who were trying to stop. So what that tells us is that those symptoms of PTSD are actually triggering people to use substances, and that is the last thing we want to have happen. So we're really moving more and more to treating both trauma-related symptoms as well as substance use in an integrated manner. And what we know from the literature is that individuals with PTSD and substance use disorders can and do all the time safely engage in trauma-focused treatment while trying to get treatment for substance use disorder. In fact, reductions in post-traumatic stress disorder symptoms during treatment is associated with reductions in substance use disorder symptoms. So it's actually really important to be treating trauma-related PTSD symptoms while you're treating substance use disorder. Interestingly enough, though, the opposite, so if you flip that, it's not true. Just reducing substance use disorder symptoms does not correspond with reductions in PTSD symptoms. So it really seems important to be treating trauma-related PTSD symptoms in addition to substance use disorder symptoms. Because what we see, again, and I said this before, is that folks who have untreated substance use or post-traumatic stress disorder symptoms have a much harder time maintaining their sobriety. So hopefully that is something that we can all sort of take to heart. If you have somebody who's really struggling with symptoms of PTSD or other trauma-related symptoms, it is important to address those while you are working on the substance use disorder. We just got a comment from Judith who said, Dr. Robert Drake out of Dartmouth did research and found that treating mental health and substance use disorder at the same time by the same team improved outcomes. And that's absolutely true. It's like treating, she says, 2 broken legs at the same time. It makes sense. It does make sense. And it can be done, and it can be done really well. And we do get far better outcomes, and those outcomes tend to last longer. So it's really great to do that. And we have a lot of evidence that suggests that treating comorbidities supports sobriety. Now, treatments can be done separately. So somebody can be getting treatment for trauma-related symptoms and separate treatment for substance use disorder, and that does work, but they can be integrated. And in fact, patients prefer integrated treatment for both disorders, which one, it makes a lot of sense. When you're living with this, it doesn't feel super separated to the patient. Those things are living and breathing in a really interactive way, and so treating them together makes a lot more sense. It also, frankly, takes less time. I mean, if I were getting treated for 2 separate disorders by 2 people in 2 different appointments, that's doubling the time. It does not appear to be necessary to do that. So there are, and what I'm going to talk about next are some treatments that treat PTSD as well as substance use disorder in the same treatment. Someone just asked me, do I recommend rapid resolution therapy or EMDR for PTSD? Either of those things have good data to support them for post-traumatic stress disorder. Again, if I were working with somebody who had a comorbid substance use disorder and post-traumatic stress disorder, I would be encouraging folks to do treatment that integrates both of those things. If you had to pick one to do sequentially, I would treat the PTSD first because, again, as I just said, the research suggests that treating the PTSD will help reduce substance use disorder. Treating substance use disorder does not appear to treat post-traumatic stress disorder, but there are ways to do integrated therapy, so you're treating both at the same time. One of the things that gets in the way of this treatment, though, is avoidance. So part of, as we discussed earlier, the problem with substance use disorder in folks who have post-traumatic stress disorder is that people are using the substance to medicate the post-traumatic stress disorder. And so asking them to disengage from that substance use behavior before you treat the post-traumatic stress disorder can be perceived as taking away somebody's coping ability, right? So how am I going to manage my hypervigilance? How am I going to manage my intrusive thoughts? How am I going to manage my nightmares if you're taking away my substance and you haven't given me anything new? So really treating these things together and get people moving and can reduce some of those barriers to treatment engagement. So I want to make sure that we finish up on time for all of you, and we will, but I wanted to introduce you to two specific treatments that have really good data behind them for treating substance use disorder and symptoms of post-traumatic stress disorder following trauma. One of them is called COPE, Concurrent Treatment of PTSD and Substance Use Disorder. There is a manual available for this. It's wonderful. For those of you who don't know, prolonged exposure therapy is an evidence-based treatment for post-traumatic stress disorder. It probably has more research data behind it than any other treatment for post-traumatic stress disorder. It is an exposure-based therapy. And there is a lot of evidence that folks who are using substances can safely engage in this treatment, even if they're not getting treated for substance use disorders. But again, my take-home message is you can do both, and you should do both at the same time. So I would not be probably doing prolonged exposure with somebody who has a concurrent substance use disorder if I can be doing COPE, which is a prolonged exposure treatment that also incorporates substance use disorder therapy directly. So this is a 12-week individual treatment. The sessions are long. They're 90 minutes. But I will tell you it works really well. And I highly recommend folks take a look at this. It is prolonged exposure and COPE is kind of broken up into different sections. The first 1 to 3 sessions are really focused on goal setting. They focus on psychoeducation both about post-traumatic stress disorder as well as about substance use disorder. And unlike prolonged exposure alone, COPE also incorporates craving control techniques in the very beginning of the treatment, because as people are engaging with traumatic experiences and their memories, which is what prolonged exposure does, that can increase the likelihood of substance use, because it has been often for people used as a way of managing their symptoms. So we really want to substitute techniques for cravings, such as avoiding triggers, using distractions, focusing on negative consequences of substance use disorder, and some thought challenging. So we do that really early in this treatment. I just got a question. Does severity, frequency of using behavior impact efficacy for COPE? No. So it has been utilized very successfully with folks who have mild, moderate, and severe substance use disorder treatment or symptoms. Now, I will say that folks need to be doing things like not using substances during their sessions or during their homework assignments. So those are things that you're going to work with your patients or your clients on to help control that in the first couple sessions that you're working with them in this protocol. So the first 3 sessions are really setting goals, engaging in motivation, doing some education. We talk a lot with folks about how they're using their substances to manage their PTSD symptoms and how, unfortunately, that actually maintains the symptoms of PTSD. And so what we do in this therapy is we really are going to approach the traumatic memory. We're really going to approach experiences that people have been avoiding. We're going to implement craving and substance use control techniques while we do that. And then starting in the sort of session 4 or 5 in this treatment, we are going to start doing imaginal exposure and in vivo exposure. So those really are things. We're going to start talking about the traumatic memory. We're going to have people go out into the community and engage in behaviors that are safe, but that they have been avoiding because of the traumatic experience. And we're going to do that while we're teaching people to manage their thoughts about drinking, while we're teaching people to engage in substance use refusal skills, and we integrate all of that into the therapy. So we help them track their high-risk substance use thoughts. We help them plan for emergencies. We get their social supports around substance use. This is often where you can engage if folks are in Alcoholics Anonymous or Narcotics Anonymous or another 12-step group. You can engage folks, their mentors and their support system, their sponsors to help with this treatment. But this works really, really well. There's been an incredible amount of research. It's really good research. And what we're not seeing is increases in substance use disorder as we're treating the PTSD. So if you can do this together, we are actually seeing decreases in not just the PTSD, but the substance use disorder behavior. And so we are not seeing one of the things that I think keeps therapists from providing integrated treatment, which is a fear that the substance use disorder is going to get out of control if we talk about the therapy, or if we talk about the trauma. We are not seeing that in the research. So I want to put this out there, and I will send this, there's stuff in the resource list on the slide deck, but I will also make sure that you all have links to the treatment manuals for this particular therapy. Now, many folks, though, many patients as well as many therapists aren't trained to do exposure treatments, and some aren't going to be comfortable with it. We are not in the business of forcing people to do things that they tell us that they're not willing to do. So you can't make people engage in exposure treatment if they're not interested or willing to do that. So there are other cognitive behavioral treatments available. And one of the others that I want to talk about is integrated cognitive behavioral therapy, which is, again, a manualized treatment. There's a treatment manual available, and it focuses not on exposure, but it does focus on psychoeducation about PTSD and substance use. It focuses on breathing retraining, symptom management, centering, and stress reduction. And it focuses on flexible thinking. So we're doing a lot of cognitive restructuring in this treatment. We're looking at the links among activating events, beliefs, emotions, and behaviors. So those of you who are cognitive behavioral therapists, this is classic cognitive restructuring, which focuses on both PTSD and substance use disorder, but it does not do specific exposure-based therapy. Somebody, Lulu, just asked if it utilizes aspects of REBT. There's a huge amount of overlap between REBT and CBT, so absolutely, we're looking at what are you telling yourself, how is that making you feel, how is that impacting the things that you're doing, and how can we break that cycle. The curriculum, again, is called Integrated Cognitive Behavioral Therapy. The manualized treatment, I will make sure that you have the links for that as well. But again, for those of you who aren't necessarily comfortable doing exposure-based therapy for post-traumatic stress disorder, this is a cognitive restructuring, a cognitive therapy-based treatment, and works really, really well. It's typically done in, it's got 8 modules, but it's a 12-session treatment. And there's some flexibility in all of these things. It doesn't have to be 12 sessions. 12 sessions is not a magic number. Some people do really well and get better in 10 sessions or fewer, and some people need more, and that's okay. That can depend on their treatment engagement. It can depend on other things in life. It can depend on, how quickly their symptoms resolve, and for some people, they don't resolve as quickly as they do for others. But both of these protocols have a lot of evidence to support their efficacy for reducing both PTSD as well as substance use disorder. So I wanted to give you those as options for treatment. I think, though, I hope the takeaway from this webinar, though, is that treating substance use disorder needs to happen in conjunction with treating the impact of trauma. So PTSD, as well as other kinds of symptomatology. Depression can follow trauma. Anxiety disorders can follow trauma. And so concurrent treatments are available. They're effective. They keep people from relapsing at higher rates than treating people sequentially. So I will make sure that you have the links to both of these treatment modalities from the FADA folks on the webinar. I have included a number of references, as you can see on the screen, that I would encourage you to take a look at as well. The literature is really exploding in this area, and it brings me so much happiness to see that we're really paying attention to this, because substance use disorder and post-traumatic stress disorder, and not just PTSD, but trauma-related symptomatology, are major public health problems. And if we can get in there and get folks treated and do it in an efficient manner, we are going to be saving lives, as well as the economic and relationship impact from these. I want to thank you all for your participation today. We have a few minutes left. I've been trying to take questions and chats as we've gone through the presentation, but does anybody have any other questions, comments, thoughts? Anything from FADA?
There was a question on the board, comparison of reduction in one issue is not conversely so. Which was which?
Okay. I think that what you're asking me is the reduction in PTSD symptoms. So what we typically see is a reduction in PTSD symptoms following treatment of PTSD and substance use disorder together. But we do, so if you treat PTSD, I think this is what you're asking me, if you treat PTSD, you are likely to see decreases in substance use disorder symptoms. If you treat substance use disorder but don't treat PTSD, you will not see decreases in PTSD symptoms. So that is why we really encourage the treatment of both of them together. But if you have to do one or the other, treating PTSD symptoms tends to reduce substance use disorder, but reducing substance use disorder symptoms does not appear to reduce PTSD symptoms.
And we had another question. Do you have any videos using COPE on the work site?
Say that again, videos, what?
Using COPE, COPE?
Do I have any videos using COPE?
Right.
No, we do not, unfortunately. I think there are videos available, but PsychArmor does not have any videos about COPE. I wish we did, but we don't.
Okay, and what is your knowledge of seizures as a result of PTSD and SUS?
SUS, is that maybe substance use disorder, SUD, substance use?
I think
symptoms, maybe?
Yeah.
Okay. So there is a little bit of literature on seizures as a result of PTSD. It's very, very rare. Does happen. I have not had a case that I've treated directly. I have had supervisees who have had folks have seizures. They, you always want to be assessing. You always want to send somebody to neurology if they're having seizures. But I've worked with a couple of clinicians who've had folks with seizures and a PTSD disorder diagnosis. They really, upon workup, if there isn't anything on scans or in neurology, we consider those kind of pseudo seizures. Now, I don't love that word because the seizures are, in fact, happening, but they are not physiologically based. They are a rare kind of psychologically based symptom. I would still encourage people to use an evidence-based treatment for post-traumatic stress disorder because if you can really approach the symptom, the trauma that is driving the PTSD, we see multiple symptoms decrease: depression, anxiety, as you've seen here, substance use disorder, not just PTSD. And we have seen reductions in pseudo-seizures following treatments for PTSD. But there isn't really a literature on that because it's so rare.
Okay. I think we're going to need to wrap up. Carie, we really want to thank you for all of your insight and the presentation. You gave a lot of information, and I wanted to remind the audience that today's recording and the presentation will be posted on the FADA website within 30 days. And if you could just hold tight for a couple of housekeeping things regarding your CEUs. Carie, thanks so much again for your time.
It was my pleasure.
Yeah, and I really wanted to also thank the audience because we know that this has been a busy and trying week with everything going on, and we've had great participation today, so thank you. As far as our CEUs are concerned, when I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. Remember, that's part of the important part of receiving your CEUs. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker, for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. In about 30 minutes, the sender will be Messenger at WebEx. The evaluation will close at midnight on Tuesday, March the 24th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Again, we thank you for participating in today's webinar, and we'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and weekend, and be safe. Thank you.